Now it's time to go into more details about the solution developed by PHIRE, which is aimed at redefining a new bladder cancer treatment. And to do this, who better than Massimo Alfano, Group Research Leader at San Raffaele Hospital and also coordinator of the PHIRE project. Massimo, please, the floor is yours.
Thank you, Marco, for the introduction, and thank you, Marco Moschini, for this exhaustive introduction about bladder cancer management. I'm Massimo Alfano, coordinator of the PHIRE project, and today I have the honor to present you the latest outcomes generated by the PHIRE consortium. So the project is about bladder cancer, which is the 10th most common cancer globally, with more than 500,000 new cases every year. Despite being only the 10th most common cancer, it represents the most expensive malignancy to treat over the lifetime of the patient. And the cost, as Marco Moschini mentioned, are steadily increasing over time because new therapy coming to the market are very, very expensive. So why this tumor is so expensive to be treated? So one of the unmet clinical need linked to the cost of the bladder cancer management is due to the presence of the residual disease. And the residual disease is associated to two limitations. The first is about diagnostic imaging, because the detection of the tumor during the intravesical cystoscopy, that is the gold standard diagnostic imaging. During the intravesical cystoscopy, the surgeon is able to remove and to reset only tumors that are visible. So it means tumors that are bigger than 5 millimeters size. That means that the tumors that are smaller remains into the bladder, and this is the residual disease. But second, the second limitation is about the treatment, because upon intravesical installation of the treatment, 50% of the patient do not respond. As Marco mentioned, there are statistics at 5 years in which between 30 and 60% of the patient do not respond. So, these two limitations are particularly relevant for the in situ carcinoma that always appear. It is always the most aggressive bladder cancer, and it always appears as a flat lesion made of few neoplastic cells. So this is very difficult to be detected during the cystoscopy. So based on these two limitations, those two limitations are the base of the residual disease. And because of this residual disease, the same patient undergo multiple cycles of surgery, treatments, and follow-ups after the first diagnosis. And this is associated with a poor quality of life of the patient and very high social cost. So PHIRE has developed and demonstrated the feasibility of a novel solution. This solution has the potential to detect and treat lesions below 1 millimeter of size. And the solution is based on the combination of photoacoustic imaging and gold nanorods. So what is photoacoustic imaging? Photoacoustic imaging is based on the photoacoustic effect that occurs when a molecule is irradiated with pulse light, and upon irradiation is able to release ultrasound. So we can detect with the ultrasound generated by the molecule. And this technique, the beauty of this technique is that it has a lateral resolution of about 1/10 of a millimeter, so more than enough to detect lesions smaller than 1 millimeter of size. Second, as a contrast agent for photoacoustic imaging, we use gold nanorods. We decided to use gold nanorods because gold is a biocompatible metal, and in the form of nanorods is an excellent agent for converting pulse light energy into acoustic energy. But we decided to use gold nanorods also for a second reason, because upon irradiation with continuous laser light, the gold nanorods are able to convert the light into heat. So gold nanorods offer the possibility to burn the cell where the gold nanorods are bound to. Therefore, gold nanorods offer the possibility to perform diagnosis and therapy of the small lesion at the same time. To make the PHIRE solution targeted against bladder cancer cells, we identified a molecular target that is the integrin alpha-5 beta-1. So overall, we identified that 81% of cases of bladder cancer do express this marker. And you can see here the expression of the integrin in these brown spots, while the non-neoplastic urothelial cells do not express the marker. Furthermore, we observed that the same pattern of expression was present in bladder cancer from dog and also in the preclinical murine model of bladder cancer. So in the next experiment, we always use the preclinical model to test and validate our solution. Next, we design a ligand that is specific for the recognition of the integrin alpha-5 beta-1. The ligand is an aptamer, and we modify this aptamer so that it ends with a group, SH group, that allow its conjugation to the gold nanorose. Furthermore, because PHIRE aims to bring this solution to the bed of the patient, we also developed a protocol for the production of targeted gold nanorose on a large scale for clinical use. So, to validate the feasibility of this solution, in particular the specificity, we use animals, the mouse model, in which the tumor was clearly evident, detectable by ultrasound imaging. So before intravesical instillation of the gold nanorose, we did not detect any photoacoustic signal from the tumor. While 15 minutes later, after the intravesical instillation of the gold nanorose, we could detect in green the photoacoustic signal of the gold nanorose on the surface of the tumor, but no photoacoustic signal on the surrounding tissue, the non-neoplastic tissue. And also we could detect that the signal remain visible up to 3 hours after intravesical instillation. So there is specificity because we detect only the tumor, and stability of the signal up to 3 hours. But obviously we want to detect the very small lesions. So in this case, we use other set of animals in which the tumor is not yet visible. We know the tumor is there because we induce the tumor, but at this time point, the tumor is not visible by ultrasound imaging. While after the intravesical instillation of the gold nanorose, we could observe at least 2 spots that show the photoacoustic signal from the nanorose. We know that these spots are specific because we measure the spectra of the gold nanorose. And then we follow so we have 2 spots that are smaller than 1 millimeter of size. Then we follow the animals in the following days, and we could observe that the tumor developed exactly in the spots that were identified a few days before from the photoacoustic imaging of the gold nanorose. So this means that also this solution is not only specific but also sensitive enough to detect very small lesions. Then, what about gold nanorose assisted hyperthermia? So we set up the in vivo condition to demonstrate the feasibility of the gold nanorose assisted hyperthermia. So with the aim we aim to identify the condition to induce hyperthermia. So in this scheme, I report the parameters that we identified. So we consider in this case the hyperthermia is induced through a laser light that comes from the abdomen of the animal. And so we identify these parameters based on the distance of the laser source from the skin, the distance of the laser source from the bottom of the bladder, and we also consider the volume of the bladder. We identify this parameter and we demonstrate the feasibility of using this parameter. So in this case, to demonstrate the specificity of the gold nanorose assisted hyperthermia, we use animals in which the tumor was clearly evident by ultrasound imaging. And after intravesical instillation of the nanorose, we could detect the photoacoustic signal of the nanorose only on the surface of the tumor, but not on the surrounding tissue. When we apply the irradiation of the animal with the continuous laser light, we could appreciate this histological pattern. What is this? Basically, this pale area is the necrotic area. So keep in mind that the nanorods are always on the surface of the tumor mass. And you can observe that this is the tumor mass and this is the necrotic area. But what is important to notice here is the specificity of the thermal ablation. Of the hyperthermia, because we also perform histological analysis of the tissue that is nearby the tumor mass. So in this case here, surrounding this tissue, we expect an increase of the temperature. So despite that there is an increase of the temperature that induces necrosis, this piece of the region that is the non-neoplastic tissue, there are no damage. But also there is no damage in the tissue that is passed by the laser light. So that means that we obtain hyperthermia only in the region, only in the tissue in which the nanorods are bound to. So these parameters are work very well. Next, we also monitor the tumor growth during the follow-up. So in this case, in this first row, there is a control group. So animals in which the tumor after 9 days from the induction was visible. We could measure the volume of the tumor that was 15 microliters. And if we do not treat these animals, after 2 weeks, the tumor fills the blood. So it reaches a volume that is more than 300 microliters. And this is our control. Next, we use animals in which the tumor, we have a comparable volume. So in this animal, there was a tumor that was detectable by ultrasound. The volume is about 8 microliters. The tumor, obviously, it has been recognized by the nanorods. We can see the photoacoustic signal in green. We perform, at this moment, we perform the gold nanoros assisted hyperthermia, and 2 weeks later, the tumor volume was 23 microliters, so much very strongly reduced compared to the untreated control. But obviously, our goal is to detect and treat lesions that are not yet visible. So in this set of animals, we, as usual, we induce the tumor. 9 days after the induction, the tumor was not visible by ultrasound, although after intravesical instillation of the targeted gold nanorods, we could detect, in this case, in this 3D reconstruction, we could detect 11 neoplastic lesions smaller than 1 millimeter of size. Obviously, we could not measure the volume. We applied the gold nanoros assisted hyperthermia, and 2 weeks later, we could see that out of 11 neoplastic lesions, we could detect only 1 tumor, and the tumor volume was very low compared to the untreated group. Also, in this case, PHIRE aims to deliver its solution to the bed of the patients. So also for the gold nanoros assisted hyperthermia, we deliver a solution that could be translated to the clinical scenario. So this solution is represented by an algorithm, which is based on the characteristic of the patients, such as bladder volume, tumor size, and tumor location. As an output, this algorithm provides a recommendation to the clinician for the parameters to be used, parameters such as laser power and time of irradiation that allow the ablation of the tumor without inducing side effects on the surrounding non-neoplastic tissue. In conclusion, the PHIRE solution offers a unique value proposition. The solution overcomes the diagnostic limitation of the current diagnostic imaging solution, because PHIRE solution is able to detect lesions smaller than 1 millimeter size. In addition, it provides a thermal treatment. Thermal treatment is a physical treatment. So this thermal therapy will not be affected by chemo or immunoresistance. It will be equally effective in male and female, but also available for frailty individuals that could not take chemotherapy. The solution also suits the current clinical scenario, so it will be acceptable by urologists because it uses catheters and cystoscope for the intravesical installation of the nanorods, but also use gold that is a biocompatible agent. Based on the expression of the marker of the integrin alpha-5 beta-1, we expect that the PHIRE solution will reduce the relapse in 75% of the patients, with a target population of more than 600,000 patients every year. Therefore, by reducing the relapses, we expect that there will be less cycle of surgery, treatments, follow-ups, and so on. So we expect that the PHIRE solution will improve the quality of life of the patient, and at the same time will reduce the cost, the social cost, saving more than $1.5 billion every year. Finally, I want to thank the innovation team of PHIRE that supported the feasibility of the PHIRE solution. I want to thank the people from Ospedale San Raffaele for taking care of all in vivo tests, identification of the target, and the project management. The group led by Mauro Comes Franchini from the University of Bologna for the design, synthesis, and characterization of the targeted gold nanodots. The group led by Jitin Joseph from Fujifilm for the characterization of the photoacoustic signal and optimization of the analysis of photoacoustic imaging. The group led by Victor Popov for the design and implementation of the algorithm for gold nanodots assisted therapy, and the group led by Francesca Natali for all exploitation activities. And obviously all of you for your attention. Thanks a lot.